want to welcome you. Thank you for being here. I'm Valerie Florence, and welcome to this, another in our series of National Library of Medicine lectures on biomedical informatics and data science. And I'm really pleased today to have Dr. Elizabeth Chen here to speak with us. So I want to, you must have seen the announcement about this, but I'll remind you of some of the reasons that drew you here, right? The work she's working on in thinking about how we can bring together information that's in the electronic health record and in the biomedical literature to both improve health and to make discoveries is a really important area. And since the broad deployment of electronic health records during the Recovery Act period, we really have a lot more to work with. So it's even more exciting to a bunch of people. She is the founding associate director of the Brown Center of Biomedical Informatics, and has this lab, the CI3 lab, right? The Clinical Informatics Innovation and Implementation Lab, doing the kind of work that she's going to be telling us about. And her interests include documentation, clinical decision support, standards and interoperability, things that matter a great deal to the National Library of Medicine. And she also is co-director of an elective class in the medical school at Brown University, where she currently resides, for medical students. So it's great, right? The more medical students that come out with that elective, the happier I'll be. And also does a lot of mentoring with high school and undergraduate students as well. She has a bachelor's degree in computer science and then advanced degrees in biomedical informatics. And she's here to talk about the very interesting work she's been doing in understanding how to use the information on social, behavioral, and familial factors that is in electronic health records in these areas that we're talking about. This, by the way, this is being videocast at NIH and will also be stored in the videocast archive, so you can watch it over and over again. Elizabeth Chen.
Good afternoon. Thank you for coming, and for those of you online, thank you for joining. So today I'll be talking about the work that we've been doing over the last several years on discovering knowledge in clinical and biomedical data and some of the ways we've been applying these knowledge discovery techniques for pediatrics and mental health. No conflicts to disclose. So an outline for what I'll be talking today. First, I'll talk a little bit about the process of how we go from data to knowledge, and then kind of delve into the work that we've been doing through our NLM-funded project on leveraging the electronic health record to collect and analyze social, behavioral, familial factors. For this project, this is a large project, kind of specifically talk today about some of the work we've done on representation, so work with standards and extracting these social, behavioral, familial factors. And we've done several domains of these factors, but focusing on the work we've done with family health history as well as substance use. Then saying, once we can extract this information, if we can integrate it, what can we learn from it? So the knowledge, so mining and visualizing these social, behavioral, familial factors, as well as comorbidities. How do they interact with each other? And talk a little bit about how we've applied these techniques for studying pediatric and adult asthma, as well as mental health conditions. So as an introduction, there's a wealth of clinical and biomedical data out there. So with the rapid adoption of electronic health record systems, we're seeing a lot of longitudinal patient information being generated that we can learn from. Also, scientific discoveries, we've seen an increase in them being reported within the biomedical literature, within databases. And so kind of seeing these two as great sources kind of to learn knowledge, so to learn disease knowledge, and seeing whether or not maybe they're complementary and how we can use them together. Kind of at the same time, we're seeing, well, there's so much data, we need lots of different methods and tools, and so there's a variety of those out there for transforming data to actionable knowledge, those from kind of extracting data as well as integrating, so from multiple data sources. A lot of data is showing up in text, so needing natural language processing techniques to extract information from text, and then kind of how do we discover patterns now? So there are data mining techniques, machine learning, deep learning, all these different techniques to actually analyze these data to learn knowledge. And so what we have is all this data, all these methods, and so what we really need is best practices. So how do we go about conducting studies of trying to transform data to knowledge? Developing community resources, kind of sharing things, open source, having tools, having community knowledge bases to really support this learning health system. And so what this picture shows is kind of, there's a cyclical process. We can go from data to knowledge, and there's a lot that goes into that. But then how do we put this knowledge into practice? And then once we put this into practice, whether it not be within the EHR through evidence-based tools that we can now implement based on this knowledge that we've learned, generate more data that we can continue to learn from. And so this is kind of that cyclical process. And what we'll talk about today is really kind of that data to knowledge. So kind of you have your study, you have to collect your data, kind of bring those data together, you want to analyze it, and then you interpret the results. And so kind of that process for doing that. So how do we go about going from data to knowledge? There's a lot of steps that are involved with this. And so in 1996, they came up with this concept of knowledge discovery in databases, or the KDD process, of saying there's many different steps. And so you kind of have to select your data, clean it, transform it, then you can mine it, and then you can interpret it. And what many of us probably know is that this part highlighted in the blue box really takes 80 or 90% of the time. There's so many data issues that we'll kind of see throughout this talk, and then I'll end with talking about cleaning it, transforming it, until we can really do these interesting analyses. Now looking at this process and applying it to the health context, and so what we did was we adapted this and named it the disease knowledge discovery process. So how do we discover knowledge about diseases? Kind of taking the same steps, same process, and saying, okay, we have all these data sources, whether or not it be the electronic health record, so EHR data is being populated into a CDR or clinical data repository that is then going into an EDW or enterprise data warehouse. Other data sources may be feeding into that. That's a great data source, but there are also many other data sources that we could look at, so biobank data, clinical registries, claims databases, biomedical literature databases. And so kind of seeing, these are all these data sources. We could study each of them individually, but then what if we want to look at them together or kind of integrate them? How do we go about doing that? Going to the next step is oftentimes you don't want to look at all these data, but you have a specific clinical or research question that you want to look at. So how do you select the data? And again, that's quite a process. You have to identify your cohort, what's your eligibility criteria, kind of how do you actually go about extracting data from all these different systems that are in different formats. And then finally, you can get your data set. But now your data set has structured data, but it could also have unstructured data. So things like free text, clinical notes, clinical reports. And so we have to do all this cleaning to really say, now we really want to use all these data together. What do we need to do? We need to clean those data. We might need to enrich it in some way so that we can actually start integrating it. And so things like natural language processing, turning unstructured to structured data, that's kind of a big task. And then being able to integrate it, so transform it into a format where we now have all this integrated data. We may have our diagnoses from both structured and free text, medications, and then we have our data set, it's integrated, and then say, okay, now we want to do some data mining, but what technique do we use? And so there's lots of different data mining tasks, some more focused on kind of descriptive analyses, others more predictive, lots of different algorithms, lots of different tools out there. And so kind of saying, which one should I apply? Or you could apply several of them, getting your patterns or your models, and then finally you have kind of the results of these data mining tasks. So how do we interpret it? How do we validate it? And so we can use visualizations to help us with this interpretation, but really kind of going to the clinical or research experts to say, this is what we found from the data. Here's the knowledge that's been produced. Is it things we already know, or does it show us something that maybe we need to look into more? So we're generating hypotheses and kind of saying, what should we do next? And getting to the step of validating those hypotheses with the ultimate goal of, again, bring that knowledge, turning it into wisdom, putting it to practice. Kind of underlying all of this are standards. Standards are really critical to each of these steps, and I'll try to highlight that through some of the studies that we've done as part of our project, and also privacy and security concerns, especially when dealing with sensitive data, things from an electronic health record, de-identifying or anonymizing the data, make sure the data is protected, it's being analyzed in a secure environment, and really being handled properly. So kind of adding this to the kind of knowledge discovery process of kind of keeping those things in mind. So with that as background, we'll spend the rest of the talk talking about the project that we've been working on and kind of trying to apply the principles of that process, or those kind of, I guess, best practices to see leveraging the EHR to collect and analyze social, behavioral, and familial factors. And so we've been doing some studies in this space, but then wanted to kind of formalize some of our work and really try to better understand the influence of a variety of kind of determinants of health, ranging from social, behavioral, psychological, genetic, and environmental factors on health. So really, there is a lot we know about how these factors affect health, kind of individual risk factors, but really needing to understand interactions and the combinations of these factors together on particular health conditions. So there are a number of reports and publications over the last few decades saying how we really need to understand the combinations of the effect of these factors. And so the one on the top, the genes, behavior, and social environment, talked about there's really this need for improved data. So thinking about, the electronic health record, now that we have this EHR data, that could be a potentially great data source, and as well as literature. And then we also need methods. So there have been a lot of methods being developed over the years in different domains, but how can we adapt them or tailor them to this context to support interactions, to support research on interactions among these factors, with the ultimate goal to enhance evidence-based tools. And so there are a series of reports that kind of motivated our work, the one on top, as well as some work on a conference on family history. Kind of while we were working on a project, 2 more reports came out in 2014 talking about the importance of capturing social and behavioral domains in electronic health record and really how that has to be better documented and represented in the EHR to be able to enable these studies and to be able to use that information in practice. So this project, we ended up calling it the SFHERE project because a lot of this information is captured in the social and family history sections of the EHR. So social and family history, so that's the SFH, and then extraction. So we need, in the case of even structured data, but particularly within free text methods to extract this information from text. Representation, so the importance of standards, so how do we represent this information, and then evaluating. If we pull it out, how can we actually use it and evaluate it? So that became the SFHERE project, funded by NLM from 2012 to 2017. Started out as a collaboration between the University of Vermont and the University of Minnesota, and then when I transitioned to Brown in 2015, ended up expanding that collaboration to include Brown University. These are the specific aims of the project, so kind of following that flow of the discovery process. Within the electronic health record, we have the social history and family history, so a kind of a mix of structured and unstructured data. We have notes, so free text data, needing the NLP to turn that into structured, so pulling out social, behavioral, familial factors from different parts of the EHR, applying standards so that we could then integrate this information. Also wanting to study effect within particular populations, other diseases that patients may have, and pulling that from structured sources, so things like the problem list in the EHR as well as billing diagnoses. And so if we kind of look at these different parts of the EHR, we apply these techniques, we kind of pull out all these different factors, we can then apply our data mining techniques. There's, as I mentioned, many different techniques. The ones we focused on is one called association rule mining, so basically trying to find co-occurrence of these factors, but not just pairwise co-occurrences, but kind of triples, quadruples, or kind of higher ordered combinations of factors to really study how they're interacting. Sequential patterns kind of take into account time, so not just are they co-occurring, but is there some kind of order in how they're occurring. And so we're seeing that maybe a patient has a certain set of social factors, but then they progress to have certain behavioral ones, then they have a particular disease, and they kind of how they longitudinally progress over time. For evaluation aim, we had 2 conditions, one being pediatric asthma and one being the other being epilepsy. And so I'll talk a little more about the pediatric asthma use case later. Just to kind of give a little more background on determinants of health more broadly, kind of these different factors that affect health. So the diagram on the left shows the rainbow model, so the different layers or different levels of influence of different factors. So you kind of have your basic demographics about the individuals, there are things about their lifestyle, and kind of expanding out things about their social environment and the community that could affect their health, and then expanding out kind of to environmental factors that all may have an effect on health and that kind of interact, and so kind of really understanding the different levels and the interactions. The picture on the right was also a figure I had found that I thought was interesting to show because it may be hard to read, but kind of on the second layer, it talks about some of these different lifestyle factors. So things like tobacco, alcohol, drug use, things about physical activity, things about how you eat, your nutrition, sleeping habits, those all have kind of an effect but kind of figure out what that is or characterizing that is the question. And so this is really just to kind of show there's many different determinants of health, a lot of different factors, and kind of it'd be great if we could kind of deal with them all, but kind of starting with, a subset. And so basically the ones highlighted here in blue are the ones that we focused our efforts on in the initial years, and so kind of highlighting them. So first, we were really interested in studying the effect of family health history, so diseases and health conditions in family members, substance use, so tobacco, alcohol, and drug use and related exposure, so things like secondhand smoke exposure that we were seeing the effect of that. Living domain, we also did quite a number of studies on that, so things like where you live, so your residence, who you live with, the living conditions, and also related environmental exposures with your living environment, and also work, so your occupation, are you employed, are you full-time, are you part-time, and also similarly related occupational exposures. So the ones in blue are the ones the ones in bold are the ones that I'll be talking about in the rest of the talk, but there are a series of studies that we did similarly for living and work domains. So just in terms of kind of the basic methods that we use for our work in representing and extracting social, behavioral, familial factors, kind of our first step was identify data sources. So, we want to understand how, say, tobacco use is represented or documented within particular data sources like the electronic health record. And then we kind of go through this process of developing annotation guidelines. So what's the key pieces of information for tobacco use that we want to capture? And developing guidelines to say, okay, we want to be able to annotate this information within text or different data sources, and then developing schema. And this can be a long process. I think in our initial studies for family history, it took about 2 years because we kind of have a room of annotators and kind of developing these guidelines. There's a lot of back and forth and interpretation to figure out, oh, this is important, that's important, these words mean this, these words should be grouped as this. So this can be a long process, but once we were able to do it with one factor, we were able to use the same process for the other factors. We then use some annotation tools, so to do manual annotation. So once we've defined what we want to annotate, being able to apply these tools to have annotators go through and look at text to kind of highlight, and I'll show some of that in the next few slides. And so the one we use is called the BRAT, Rapid Annotation Tool. Based on this, once we've kind of have all this, these information annotated, we can generate information models. So that's kind of like, oh, we have tobacco use. What does it mean? What information defines tobacco use? And I'll show some of that. And then because we want to develop natural language processing tools, a big step is generating reference standards. So what we want to be able to compare the automated output of NLP tools to kind of a manual reference standard, so being able to generate that as part of the process. And then once we have that, we can develop our NLP tools, and at the University of Minnesota, they've been developing an NLP system called Biomedical, or the Biomedical Information Collection and Understanding System, using the UEMA, or the Unstructured Information Management Architecture Framework, so open source, and saying now we've developed these standalone modules, but let's integrate it into this larger system. So this system can now pull out kind of clinical entities, as well as these social and behavioral and familial factors. So in terms of data sources, EHR systems, that was kind of our primary data source, but we did look at other data sources. And so because this was a collaboration started between the University of Minnesota and Vermont, we looked at EHR data from Fairview Health Services, that's affiliated with the University of Minnesota. They had been on the EPIC electronic health record for several years, so we were able to study social family history information from that. At the University of Vermont Medical Center, they had more recently transitioned to the EPIC electronic health record, and they also had a legacy EHR system. So we were able to look at data from both the legacy as well as EPIC. MT Samples, that's a publicly accessible repository of transcribed reports, which also is a great resource, I think, for especially when we're trying to develop community resources to be able to develop some of these techniques. The University of Pittsburgh Medical Center had made a notes repository available for NLP research. And then more recent work, we used EHR data from the Medical Information Mart for Intensive Care, or MIMIC-3. So that's EHR data from Beth Israel Deaconess Medical Center for ICU patients. In terms of data types, so depending, some of these data sources had all EHR data or subset EHR data. Some were just notes. But kind of thinking for the ones where we were able to get kind of more breadth of EHR data, we were able to get things like demographics, so kind of basic structured information for kind of conditions and diseases, diagnoses, chief complaints, problem lists, past medical history, all providing information about conditions and diseases. Our focus, as I mentioned, was on family and social history. So within the EPIC EHR, that's collected as structured information, but there's also some free text there. There's also flow sheets, so a lot of things about asking questions and responses. That, again, also is a mixture of structured and free text. And finally, clinical text. And what we had found through these studies is what we've called short text. There are kind of snippets of text throughout the EHR, whether or not they're in flow sheets or within the family and social history, the kind of brief comments that are basically 255 characters that maybe the structured fields aren't sufficient, so you're going to add some information to the text, but it's not the same as a full-length clinical note. And then we have full text or clinical notes. And then what we can see here is going from structured, so those data are structured, but as we kind of go down, it becomes increasingly unstructured. And so there's lots of opportunities to apply NLP techniques to actually turn the free text into structured data. And just to kind of show an example, so here's an example of a note that we can find in that empty samples site, and just to kind of show what it looks like, what family and social history information looks like. So we kind of have our highlighted in blue. We have our sections here, and it talks about a condition and family members. And so the goal here isn't to actually pull out all the information from here, but what's the key pieces of information? So things like in the family history, we want to know what the condition is and who's the family member and their kind of living status. Social history, similarly, things about substance use. There's, in this example, information about occupation. And so kind of figure out in terms of our modeling, what's the key pieces of information that makes up a family history or substance use or occupation. Other data sources, so this is kind of a long list, but just to kind of show, we had initially planned to just focus on the EHR, but when we started thinking about information modeling and really representing the breadth of social and behavioral familial factors, really wanting to see, well, we should probably look at this from different perspectives and actually get a better sense, a broader sense of how we would want to model this information. So things like we looked at public health surveys. So these are some examples of those maintained by the CDC, where they collect information about behavioral factors. So like the behavioral risk factor surveillance system asks lots of questions and gets responses about things like tobacco use and kind of what are being asked in these surveys. How do those relate to what's actually being documented within clinical charts or within the EHR? Similarly, we had done, particularly with family history, we're looking at patient-facing tools. Those things like the My Family Health Portrait from the US Surgeon General and the Family Healthware from CDC. What questions are patients being asked about their family history? Again, how does that relate to what's being documented within the EHR? Also for research measures, for research studies, similarly, if we were going to take the tobacco use example, what are questions or guides in the Phoenix toolkit or common data elements that are being collected right now? And again, how does that relate to public health surveys or clinical text or these patient-facing or consumer tools? And finally, standards. So kind of we have these models, but what about standards? So HL7, they have family history model. OpenEHR has lots of different archetypes, including those for family and social history. What do they define family history or tobacco use to be? Other ones, more specific, things like the Occupational Data for Health model from the National Institute for Occupational Safety and Health. They've been developing models for occupations. So kind of seeing what's out there, are they adequate to represent what we're seeing in the EHR, and look at ways maybe how we can enhance these existing models. And then the key piece to this is then kind of we have the structure of the information, but what about the terms or the values within them? So looking at how social behavioral familial factors are actually being captured within things like SNOMED, which kind of is broad, and LOINC for observations, and then also there's one specific to like occupation, like the standard occupational classification. So these are many of the, just to kind of give a sense of many other data sources that we ended up looking at to really complement the EHR. And the one I kind of skipped over is biomedical literature, which I'll talk more about later, is also, we spent a lot of time looking at that, particularly PubMed and Semantic Medline, and I'll talk a little bit more at the end about some ways we've been looking at the literature. So now taking all that together, here's what we found for the family history model. And so on the left, this is actually our first study that we had done just by looking at clinical notes. So these are just family history sentences that we were looking at. And the intention of this project was to say, is the existing HL7 models for family history adequate? Can they represent what we're seeing in clinical text? So on the left is kind of our visual representation of the family history model. On the right are some examples of family history statements with the goal of saying we want to be able to develop a model that can capture the key information that we're seeing in sentences and statements. And so what we're seeing is there are two parts. There's family members, so you want to capture who the family member is, and that maybe there's other information about the family member that should be captured. So which side of the family, some demographic information, is that family member living or deceased, and if they're deceased, what's the age or date of their death. On the observation, so that we can think of that's the disease or condition that the family member might have, and so we need to know what that is, and there may be information about when that condition was diagnosed or at what age. There's a certainty or the negation. So is it that you don't have a family history of a particular condition? So if you look at the example in the bold, it says a sister was diagnosed age 45 with breast cancer. And so how we would then populate this model is it tells us that the family member is a sister, the observation is breast cancer, and the age of onset is 45. And so we could do similar things with the other two to kind of make sure that this model would work to capture the information within those three sentences. The last two are other ones that we actually ended up seeing, so not really represented in this model, but we ended up incorporating it into the next one, kind of general statements about family history and other information. So that's what the new model ended up looking like. And so the Venn diagram shows this was a much more comprehensive study that we ended up this is the one that took several years, where we actually looked at more notes to make sure that model was sufficient. So it may be hard to see, but on the table on the very left, it says Model 1 had 16 elements, so that was the one we just looked at. We looked at more notes, looked at more family history sentences and sections. We also brought in tools, so we did a survey of patient-facing family history tools. I think there were about 10 or so out there, and we just said, what are they asking? What are they collecting? How does that compare with what we're seeing in clinical notes? And then specifications, that's really our standards. So we said HL7 had several standards on family history. There are a couple of reports, other standards, whatever we could find out there that says this is what you should capture for family history, and really trying to have a comprehensive view of it, taking it all together. And so on the table on the right, it says now the second model now has 44 elements based on looking at all these different data sources. And the Venn diagram kind of shows there is some overlap, so 16 out of 44 we found across the three different types. But there were some things unique to notes. So an example of that in the table we see it says strength of observation we only saw in the notes. And so that was cases where we said it would say strong history of cancer in a family member. And so kind of looking at the words, and so that's where that came from. We also saw things that were some unique to the standards, but also things that were not in the first model. So here's quantity of observation. We were starting to see phrases like multiple strokes, and we thought, oh, it's important to capture, it's not just one stroke, but at multiple, and that becomes its element within itself. So that was our family history model, and as I mentioned, we were trying to do a lot of this annotation to kind of help inform the NLP. So the NLP module we started developing at the same time we were working on that second model. So it's essentially based on the first model of trying to first detect family history sentences and statements from clinical text, then within those statements find the entities. So find the family members and observations. In this case, the observations are like diseases or conditions. And then the predications. So we want to be able to relate, because sometimes there may be multiple observations for a family member, to create the relationships between family members and observations. And then extract attributes, so negation, so things like making sure it's not that if it says no family history, we need to be able to capture that. Capture vital status, knowing if a family member is alive or deceased, and also age of death, kind of all things that were shown in that first model. And so here's an example of some of those sentences, how they were annotated manually by members of the research team. This was using that BRAT tool that I mentioned. And so if we kind of look at the first example, it says mother died at age 79 of a stroke. And so what we did was annotate mother as a family member, stroke is the observation, then there's a relationship, so that line between those two is basically that predication, so showing that it's a stroke in the family, in the mother, and then vital status is essentially the attribute, so the vital status of that family member, and then the age of death is also an attribute of that family member. And so essentially this is how we manually did it, but basically the NLP module would do the same thing. And so we did some of the comparisons, and so that's what the F scores represent based on the recall and precision values of the performance on kind of our initial NLP module. And so you can kind of see there's a range going from about 67% for detecting family history statements, for entities and relationships, a little higher for the entities, a little lower for the predications. And then for the attributes, again, seeing a range, but seeing it does pretty well with vital status, not as well with negation. We're really pointed to a lot of things that we could do to improve the performance. Similarly, we did work with substance use. And so this was the initial model, again, based on just looking at clinical text. And we found, and this would cover tobacco, alcohol, and drug use. And saying, based on looking at this clinical text, we're seeing that there's kind of 6 major elements of information that we would capture for substance use. And so again, the initial model on the left, examples of some sentences or statements for substance use that we want to make sure we could represent with this model. And so looking at the first one, she smokes 5 cigarettes per day, has done so for 10 years, and seeing how it would fill into the model. So status basically is inferred based on just how it's written. It doesn't seem like it's information about past use, but it's about current use. Temporal, so the 10 years fills in with the temporal. Method, smoke. Type is cigarettes. Amount is 5, and frequency is daily. And so this was, as we can see with some of the references, we then did a series of other studies, some just focused on tobacco use, some on alcohol use. We did a particular study on e-cigarettes, and then one on drug use. So taking all those studies together, we ended up coming up with the next version of this model. And so that's what this looks like, and I'll try to highlight some of the main differences. And so we still have that same 6 elements, but what we did was really expand on temporal because we were seeing all kinds of temporal information showing up, and we can see some of the examples highlighted in purple is that sometimes there will be start and dates and ages, quit dates and ages, duration of use, duration since quit, all kinds of durations and time frames. And so we basically, just like the other study, this wasn't just based on clinical text, but we looked at research measures, so things in the Phoenix toolkit, the common data elements. I think we also looked at some of the public health surveys all together, kind of seeing, bringing it together to build a more comprehensive model. So there's lots and lots of temporal information. Other things that we were able to add, particularly when we were looking at text about tobacco use, we were seeing a lot of sentences about secondhand smoke exposure, so we ended up adding this part of context, location, subject. So the one on the top, grandmother smokes e-cigarettes in the home. To represent that, grandmother would be the subject, home would be the location. And so that was built out because we were seeing this within the clinical text. Also we were seeing things like social glass of wine, so we end up saying that's kind of a situation. It doesn't really fit into the other things like amount and frequency, and so we came up with that kind of new element of situation. And then when we started to look at some of the text, I think particularly about e-cigarettes, and then some of the research measures, we were seeing things like change, so cut down to 1 joint per day, so things about changes in drug use, and then things like triggers, evidence of dependence, and cessation. So we were starting to see text talking about that. So wants to stop using heroin, recovering alcoholic, offered quit line information, declined. And so those are all things that were starting to be showing up in text that we said should be added to the model. So similar to family health history, we use this to kind of inform the substance use NLP module. So similarly, taking the first version of that model and trying to find first social history sections and sentences, so looking through the text, applying methods to actually find these sections and sentences, then detecting statements, and so now we had to deal with 3 different substances, alcohol, drug, and tobacco use, again, seeing about similar performance, about those kind of in the 80s for the F scores, and then for each of those, and these are averages across those 3 substances, how well it does with pulling out information about amount, frequency, status, method, type, and temporal information. So again, seeing a range, it did really well with type, so things like cigarettes, wine, beer, heroin, marijuana, and then less so with temporal, but I think with some of the work we did with the second model, that may improve. And so again, here are some examples of the annotations in BRAT. And so looking at the third one, she drinks 2 to 3 glasses of wine per week, and so we could kind of see manually how we annotated and essentially building the NLP tool to be able to extract the same information to have those kinds of relationships between the amount, type, frequency, and method. Okay, that's kind of the work we did with representing, building these information models. We did for family history, we did it for substance use, developing those NLP tools. I'll kind of shift a little bit now to talk about some of the kind of the analysis and what we can actually learn from both the EHR as well as literature, and kind of show how it all ties together at the end. So, as I mentioned earlier, our focus was on studying two techniques. So one, association rule mining, essentially a non-temporal data mining technique, studying co-occurrences of social behavioral familial factors and comorbidities for particular diseases, and also looking at temporal patterns, so sequential pattern mining, and really being able to study the trajectory of these factors and comorbidities for certain populations. These are methods that have been around for some time. They have many challenges that are known. And so one of the things is really we're trying to find all different combinations of things. So you can imagine that the search space becomes huge. And so what these techniques do is they produce lots and lots of different patterns, lots of temporal and non-temporal patterns. And some of the patterns are just noisy, so things that you wouldn't really want to see, things that are kind of known or obvious. But also what happens is you may end up losing things that happen very rarely among all these patterns that are being generated. Some ways you can deal with it is with these things that they call interesting measures. And so these are basically different metrics or statistics that can be applied to say, how often does this co-occurrence or this pattern occur? And so things like support, that's essentially a frequency. Confidence kind of takes into account previous knowledge. And then chi-square is another one. And there's just a huge range of different metrics. And so one that we found to outperform the others based on prior work was chi-square, so that's one you'll see that we show some of the results for. But there are also many other metrics that, depending on which ones you use, you'll get different rankings of these patterns. You can use them to filter, but then if you set these thresholds at certain levels, you may end up losing patterns. And so there's all these different trade-offs. And so part of the work was trying to see what can we get with these techniques and how might we be able to optimize them. But I think it's really a work in progress. There's a lot that could be done. And then levels of extraction, which I'll talk about too, is, the data sometimes are very granular, and if you kind of try to generate patterns on them, you'll get lots and lots of little patterns, and nothing will actually kind of be highlighted. So a way to deal with that is to kind of group codes or group information together and then apply these techniques, which we'll talk about. In terms of open source tools, at the time when we started this work, we were using R. So there were actually packages already for doing association rule mining, sequential pattern mining. So what we thought we could do is let's try to leverage those, and we add kind of the initial, so the data extraction and the cleaning things, add that into the pipeline, and then use those visualizations. Over the years, we've been transitioning to the Julia general purpose programming language. So we've been transitioning all our code from what was R, using kind of our early work as these are prototype feasibility studies, now translating our code into Julia and making that available. So we've done an early implementation of the association rule mining algorithm, and I've also been doing some work with the sequential pattern mining. And then in terms of evaluation, what I'll show are some of the work we've done with pediatric and adult asthma, and then some of the things that we've done with mental health conditions. Again, there's been a lot of work on studying risk factors for these conditions. A lot of things are known, but what's been written in the literature is we need to really better understand interactions between the different social, behavioral, familial factors, and we really need to build upon the knowledge that we already have. So a lot of what these studies will show is how we're trying to add to this, kind of build tools and methods to enable these studies so we can actually get a better sense of the interactions between risk factors that could then potentially contribute to improved risk assessment of these conditions. So this was one of our first studies. So this was on family history associations for pediatric asthma. So looking at the EHR, there's a family history section within them there where you can document a problem and then the relation. So a particular condition that a family member might have or a family member has. So this table kind of shows what could be entered. So this is basically structured. So problem and relation are structured fields. There's pull-down lists you can pick. So in the first case, you can select asthma and then specify the relation. So it's asthma and the mother. There is a free text field, and so we didn't use that in this study, but we had another study trying to figure out why is this free text field being used. So this is what I mentioned early on as short text and how we see that appearing throughout the EHR, where things where when it can't be captured in the structured fields, information is being put into the comment, but that information may be really essential. And so how do we actually integrate it with the structured data? So there's another example here, the one on the third line. So problem has that asterisk because it probably wasn't on the list. So what they ended up doing is put it into the comment. In this case, it just says healthy, so knowing that they have a healthy brother. The fourth example has problem is cancer. The relation says other, again, probably because it wasn't on the pick list. So now that's going into the free text. And so maternal great aunt is showing up as a free text in the comments. And then also what can be captured within this family history module is negative history, so that there's negative history of a particular condition. So we could actually study that as well. The two columns on the right are things that aren't captured, but things we inferred as part of this study. So again, talking about the levels of granularity, that's very granular. If you say mother has asthma, family history of mother with asthma, it's very specific. And so if we kind of try to do data mine at that level, we'll get lots and lots of different rules, and kind of the statistics will be pretty low. So we explore different things of trying to say, well, let's look at maybe side of family, because that's what the literature talks about. They talk about maybe if there's a family history in a maternal or paternal side, or first and second degree relative, you may be at more risk. So let's translate those into side of family as well as degree of relationship where possible. So in some cases it's not possible, but let's see what happens. And so that's what the second area says. We wanted to look at rules at different levels of granularity. So first problem, so family history of asthma, and then specifically within a relation, so family history of asthma in the mother, or family history of asthma on the maternal or paternal side, or family history in the first or second degree relative. And because they're also capturing negative history, also maybe studying that. And so taking all of that, applying our data mining techniques, and so here we use association rule mining to do this, generate visualizations of that we could then kind of see, does it confirm what we already know, but maybe it points to something that we could actually look into further. So these are the visualizations that we got from that analysis. And so some of the things we found here were things that we kind of are reporting in literature, and these are all things that are family history. So even though it only says the conditions, really family history of asthma, family history of allergies, family history of food intolerance. So those are all things, if you look at the literature for pediatric asthma, known risk factors, those are all known risk factors. So I guess in good things, it tells you what we know, but also it says, maybe this is a reliable data source that we can use for studies like this. It's at least confirming what we know, but maybe there's something else interesting we might learn as we continue to go along. Also down here is a set of mental health conditions, so things like anxiety, depression, substance use, bipolar disorder. So these are things, if we look at the literature, they don't say that there's family history associations, but these are known comorbidities for asthma. So again, not really about family history, but still validating kind of things. If this is being captured for family members, it may be just saying that this family member has these mental health conditions as well as these other as asthma and allergies. And then what this cluster shows is a lot of different chronic conditions. Again, if we look at the literature, comorbidities for asthma, but also these are things that we might see for other conditions or the general population. So some of the things this kind of told us was, well, we need to enhance our techniques to filter out things that may not necessarily be unique to the pediatric asthma population. And so kind of pointing to kind of next steps. And so this was at the very, I guess, general level, so family history of these conditions. This visualization kind of shows things on the degree of relatives, so family history of these conditions or in first or second degree relatives. We zoom in, again, we kind of see similar conditions as we do on the one on the left, so seeing things like allergies and mental health conditions of first degree relatives. And then one I thought I'd point out is hearing loss showed up here. And so when we looked at the literature about this one, we didn't find anything that directly said asthma and hearing loss, but we were finding articles about asthma and otitis media, so ear infections, which then might lead to hearing loss, and so kind of that indirect association. This next study, kind of building on the previous one and kind of we're seeing all these patterns related to mental health, and we actually want to see what we could do with these sequential pattern mining techniques. So this was a more recent study that we ended up doing with the MIMIC database. So that's EHR data for ICU patients at Beth Israel Deaconess Medical Center, and kind of saying, let's look at patterns within asthma patients that have mental disorders and those who do not. Again, looking at different levels of granularity or different levels of extraction, so similar to family members where we wanted to look at them at kind of different groupings, doing the same thing for diagnoses or comorbidities. So we have them in this data set as the diagnoses as ICD-9 CM codes, but saying, can we group them so that we could, again, avoid having so many rules with very low numbers and kind of start grouping them so we can actually see things at a broader level. So there are a number of groupings out there, but the one we've been using is called the Clinical Classification Software, so maintained by HCUP, the Healthcare Cost and Utilization Program, and they have a way of grouping, but there are many other groupings out there. So grouping at what they call single-level CCS, so about 285 categories, so taking down the many thousands of ICD codes and kind of having them into smaller groups. The multi-level CCS, so kind of a hierarchical grouping, which I'll show on the next slide, and also even at the higher level, so ICD chapters, so it's kind of seeing just broad patterns of that we're seeing. Similarly, applying data mining, this time instead of doing the association rules, we're looking at sequential patterns, and then again with visualizations. So just to kind of show some examples of the levels of extraction, because this ended up being very important throughout all of our studies, is different ways to group concepts. And so we have at the ICD-9-CM level these two diagnoses, so asthma not otherwise specified and depressive disorder not elsewhere classified. If we were to use the single-level CCS, these get grouped up with either ICD codes into an asthma group or mood disorder. And then here's with the multi-level CCS categories is we have the same code at the bottom, but then we can look at these patterns at different levels, at least 4 different levels. So again, they'll tell us different things. They get less and less granular, but maybe some things will start to kind of come out as we group them at these different levels. And then finally, at the ICD chapter, so kind of the high-level categories or high-level groupings. So these were some of the visualizations. So this is sequences, and this is a Sankey diagram. And so asthma with mental, asthma without, just visually you can kind of see the one on the left is much more detailed or has a lot more than the one on the right. What it says is from left to right, so at certain admissions, so if patients in this cohort had multiple admissions, on the left would be conditions or diagnoses we saw in one admission, then the middle one is conditions we saw in a subsequent admission, and then the ones on the right is ones in kind of a third admission. So kind of starting to get to these sequences. And so there's 2, those kind of show, both of them have, I guess, at least 3 points for the one on the right and the left. And then here, if we could zoom in, it might still be hard to read. The one on the top is the one from the left, the one on the bottom is the one for the right. But we can already start seeing these temporal patterns and seeing, maybe here in the middle we're asthma, but what are conditions that we're seeing before and after when they have mental health conditions or when they don't. And then part of this, what we're trying to see is getting towards some comparative analyses, or what do the patterns look like when we look at different populations. So this is a Venn diagram showing, and this is that was the multi-level CCS, this is the single level. Here's an example of the patterns here, but there's some overlap, and so that the Venn diagram shows about an overlap in the sequences that we're seeing, but there are many more that are unique to the group with asthma with mental disorders, and then the ones without. And so part of the motivation for this study is we know, as I mentioned, a lot about risk factor for asthma, but less about kind of the temporal relationships. And so this was a way to start getting towards studying that and seeing, again, we might validate what we already know, but is anything coming out by looking at this EHR data set? Here's Comorbidity Miner, and so this was after we did those studies, we said we should probably turn this into a tool, and it can be generalizable. It doesn't just have to be the MIMIC data set or another EHR data set, but and then trying to address some of the terminology issues and data abstraction issues. And so here we started looking at another data set called AOLIS. So this is a standardized version of the FDA's adverse event reporting system. And knowing that that's using, so in one case, diagnoses are represented as ICD-9 codes. In AOLIS, it's SNOMED CT concepts. And so how do we actually kind of integrate knowledge from these? And so looking at CCS as a way to kind of group, to enable comparisons, doing the same thing with association, sequential patterns, generate these visualizations. And so this is what the interface looks like for Comorbidity Miner, and this is developed using the R-Shiny as the web app, where you can specify the data source. You can do these different explorations on the left. So explore all the full data set, explore the cohort, so kind of a demographic analysis, look at sequential patterns, look at association rules, define cases and controls. Here, in the case, we've started to do some more studies in mental health, and particularly understanding conditions that may lead to suicide. So looking at suicide as well as patients with suicide-related diagnoses, as well as those with mental health conditions. And then starting to explore, and I know this is hard to see, but association rules, again, kind of showing what we know about there's association between suicide-related diagnoses as well as mental health conditions. And there's some other things that we're seeing here, hypertension and chronic kidney disease, and also substance use conditions. And then similar as what we've shown in the previous one, sequential patterns we can also generate from here. Not as interesting because there's only kind of 2 time points. But again, just trying to develop a tool that can accommodate for different data sources, different terminologies into kind of one place, and with the ultimate goal of being able to allow for comparisons between knowledge we're getting from different data sets. So that was a quick overview of some of the stuff we've done with EHR data and some of the tools we've been developing. Kind of want to shift a little bit to literature. And so we ended up doing these in parallel while we were doing the data mining, the clinical data mining studies, but trying to see, we'll want to validate this and using the literature both as a way to validate what we're seeing from the EHR analyses, but also, is there complementary knowledge within the literature? And so in parallel, we worked on developing a prototype of a tool called PubMedMiner, and kind of a similar process of we want to be able to search literature for particular topics or searches, extract the mesh descriptors, filter them by UML semantic types. So similarly, what we did before is wanted to find what are diseases or conditions or mental and behavioral dysfunctions that are co-occurring with mesh descriptors for the search that we're interested in, generating basic statistics, and then also being able to find association rules. Again, not just pairwise or just frequencies of other ones, but can we see there's a lot of these other mesh descriptors are co-occurring with your topic of interest. So this was one, again, this was developed in R because they had existing R packages. And again, we wanted to kind of highlight how these packages could be used to both find these association rules, but then be able to be used for comparative studies. So combining, if we did a search for articles related to pediatric asthma and adult asthma, what do we get? And so these are ones that show, there's some mesh descriptors or conditions that we're seeing in both of these populations, but also conditions that we might only see in the literature for pediatric asthma, and ones that we may only see in adult asthma. And then one here is, most of these are pairwise, but this one showed a triple association between allergic rhinitis and atopic dermatitis. So what we're in the midst of doing now is that was pretty much a static app. We could run this code and actually generate these static visualizations. We're now in the process of turning this into an interactive web-based app. And so starting with some basic functionality where you can enter a mesh descriptor, specify semantic types to filter the co-occurring mesh descriptors by, and generate these visualizations. These are all interactive visualizations, and I'll zoom in, but on the top there's some other matrix-based visualizations that you can see using different metrics, and we're still kind of adding to these different metrics. But this one is basically a core diagram, so for kind of the more frequently co-occurring mesh descriptors with suicide, you could kind of explore them, pick one that you might be interested in further exploring. So in this case, I think we've clicked on anxiety. You see this thick line between anxiety and depression showing that there are many more articles on that. And then if you click there, what populates is this tree-based view, where you can now say, well, there's articles about, in the suicide set of articles, there's also ones about anxiety. If we then look at depression, there's also ones about these other conditions. And then there's a button actually on the bottom to actually go into PubMed and kind of search this whole path. And so again, just an exploratory tool that we're working on developing for literature mining to kind of explore the literature and really study these conditions. So I know I'm starting to run low on time, but kind of wanted to talk about some of the challenges and opportunities and some of the studies that to highlight some of these things. And so with all this, we've done a lot of things with standardization and representation, NLP, data mining, but our ultimate goal is really to help facilitate discovery across data sources, so across the EHR literature. Data types, we kind of saw there's a lot of structured data, free text, really going across all those data types and populations. So we talked about some of the studies we've done with pediatrics and mental health and things that we want to do more with those, as well as being able to do comparative studies to really study interactions among these social behavioral factors for a broad range of conditions. So we talked about some that we've been studying, but really to kind of build these generalizable tools and processes. Kind of some of the lessons learned, which were challenges, but also I think a lot of great opportunities. And so there's, I think, a lot more work to be done. But some of the things we spent a lot of time, as I mentioned, on studying the current representation and collection of these factors from different perspectives, not just from the clinical or the EHR perspective, but looking at it from the consumer perspective as well as researcher perspective and public health to kind of see how can we represent these more comprehensively. Particularly with the EHR, we looked a lot at the different texts, particularly those comments were of great interest to see, why is that comments field being used, and is that an opportunity to potentially improve EHR system design, improve training, and so there's a lot of kind of clinical implications of can we maybe affect documentation practices, but we really need to understand them and using the data to understand how are things being documented, what are current documentation practices, and how can we inform maybe improved documentation practices going forward, which will then end up producing better data for clinical purposes as well as research purposes. There's a lot of opportunity to integrate data and knowledge from disparate sources, but a lot of challenges. We saw some of the examples with different data sources have different data structures. They have different terminology systems, and how do we deal with that, both from the data perspective and also the knowledge that gets produced from it, and if we want to integrate those knowledge from the EHR as well as the literature. Being able to explore things at different levels of extraction. So we did some of that with the CCS, but also we could look at the UMLS hierarchies to study how do we group comorbidities in different ways to then apply these data mining techniques. Data quality issues. So data quality issues abound. So inconsistent data, incomplete information. We need to really study the data to know what those issues are and then come up with ways to deal with those data quality issues. The methods we used, we know there are a number of challenges, so we tried to look at ways to optimize those methods, and I think there continue to be opportunities to look at how can we produce higher quality patterns, both non-temporal patterns as well as those temporal, and really kind of get towards conducting more robust clinical validations. We have these methods, we have these tools, we're really seeing, is it producing knowledge that's useful? Are we both validating what's known, but can we potentially validate unknown interactions that really are hypotheses to look into further and really enable comparisons between different populations. So I just wanted to highlight two more studies to kind of highlight some of these challenges. One is one we started to get towards combining knowledge within the EHR and literature, and this was a study we did, one of our medical students who was interested in obstructive sleep apnea, kind of finding that there are some known comorbidities, but not a lot of work in mental health and studying the effect of OSA on mental health conditions either before or after. And so what she did was kind of look at both EHR data as well as literature. Again, one has ICD-9-CM codes, one has message descriptors, leveraging the UMLS Metasource semantic network to kind of standardize two UMLS concepts so that she could then do analysis and comparisons across these data sources. And so this was a Venn diagram that was generated based on that. I know it's very small, but it's kind of showing that there's not too much overlap between them. I think there was a kappa calculation. The number ended up being very small. Really, the overlap is kind of there in a shaded area here. But what our kind of thinking was that it may be a granularity issue with the terminologies where the EHR data is more granular than the literature data, and so there are ways that we could address that. But it was a kind of initial study to say for this particular clinical question, kind of seeing what we would need to do and kind of how we could address some of the issues we were seeing. And the one thing that she found that she was interesting that wasn't as reported were cognitive deficits, not being reported as much in the literature. The ones kind of in the overlap were being reported as being associated with OSA, but cognitive deficits was an area to kind of look further into. And then this one, speaking with data quality, here's an example of structured tobacco use documentation in the EHR. All the top ones are structured fields where you can kind of pick certain values or type in certain values. The comments is really free text, and so we had done an early study comparing the quality in terms of what's showing up in the comments versus what's showing up in the structured fields. And we're finding all these different quality issues. So things like inconsistent smoking status. In one place it says never smoker, and another place occasional cigar. Things like inconsistent start and quit dates. So quit date was specified as 1975, but in the comments it said quit in 1980s. So again, kind of speaking to if we're going to use, do you use the structured data or the unstructured? Which one's the right one to use? And then also this potentially causing issues for natural language processing, use of acronyms and abbreviations, misspellings for smoking cigarettes, ambiguous information, so putting a year but not knowing is that the start or quit year of tobacco use. And we're even seeing things in the comments of things not related to tobacco use, so things about drug and alcohol use, and whether or not that's the only place it's documented. And so we're kind of losing information if it's not documented in the correct place. And then here's a study we kind of did for longitudinal, so especially with a lot of longitudinal studies, what are we seeing? And so the one on the bottom said for this particular patient, we're seeing all this information, tobacco use information being reported in a note that's different. So depending on when you're doing the study, which one of these do you use for the tobacco use information? And kind of highlighting the value of looking at, there's at least 3 parts in the EHR that tobacco use information is being documented within these structured fields, within the comments and the notes. All maybe they're consistent, but maybe they're not. And so, and if they're not, how does that affect your subsequent analyses? So in conclusion, kind of going back to this diagram that we looked at early on, and now kind of somewhat tailored to the SFHERE project, social family history. What we've tried to look at is, kind of going from the left, is really looking at the electronic health record and biomedical literature as valuable and potentially complementary data sources to study social, behavioral, familial factors and their interactions. Over the years, we've developed a number of tools, so both the information models that we saw, the ones for family history of substance use, but we also developed ones for living and work domains, and kind of the implications of that for kind of standardization and integration, developing natural language processing modules to pull out these factors from text, and also data mining tools to be able to mine knowledge. And so we had the Comorbidity Miner tool as well as PubMedMiner. We're now looking at integrating them into a single system, knowing that we're interested in kind of comparing knowledge from different sources. And so the hope is with these tools and others that are already out there, we can really support and enhance both existing and new knowledge, and also work towards creating kind of community knowledge bases. So we can find these things and study it, but really put it in a knowledge base to disseminate this knowledge, as well as enable others in a broader community to actually use that knowledge, ultimately to develop enhanced evidence-based interventions that incorporate these factors. So this small set of social behavioral factors, but kind of more broadly to improve identification, risk assessment, and treatment. So I'd like to acknowledge many who have been involved with this project over the years. So there are many PI from the University of Minnesota in particular, and also the many faculty, staff, and students who have been involved with this project over the years for different parts of it. And of course, support from the National Library of Medicine for making this work possible, and also allowing me to present this work to you today. And some of the resources, so our publications and presentations are available through the SFHERE Digital Repository, code available in some of these other resources. And I just want to thank you. Some combination of both. So we did a study specifically for tobacco, alcohol, drug use, comparing comments and structured, and there's things that show up in the comments that don't show up in the structured at all. I think we probably would need to look at it more to figure out which one is more reliable. I think we hadn't quite gotten to that step yet, but we were finding there's a lot of rich information showing up in the comments. So I think those are opportunities to kind of look into more of which one we'd actually use. And I don't know if we could pick one or the other. I think both will have issues if you only use structured. Things like e-cigarettes, at that time, it's probably different now. We're only showing up in the comments. So if you're trying to do a study in e-cigarettes and only using structured, we'd lose all those. We wouldn't find anything. So that's the disadvantage of structured. If you look at the comments, then we kind of need NLP to actually be able to use that. So I think that's the opportunities is really to know that it can be documented in multiple places, The other place it could be documented is in the problem list, where they might have smoking use disorder and things like that. So I think there's probably a balance between the different parts of the chart. But I think those are some of the open questions to figure out is which one, or is it some combination? Yeah, it's true. Yeah. 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 First question so we did for the natural language processing, and so we had access to some of the data sets, so the MT samples, which is the public repository of reports. There was also the Pittsburgh notes, and then Fairview. And so one of them, it was, depending on the study, one of them served as the test set, and then one in the training. So that could be the reason why performance decreased as well, or no, the reverse, the training and the test. And so, and this is kind of things that happen is you build it for one and it doesn't work as well in the other. So I think that was kind of an initial study. I think that's things we need to look into more of why the performance is low, because it is true in other studies with negations it's very high. And so those are things that I think we would need to improve. But things that, there were challenges of looking at data from, terminology things, looking at things from Minnesota and Vermont. We found even with the family history where we saw those lists of family history members and relations, those behind the scenes weren't standardized codes. Those were local codes, and kind of thinking about some of the data integration issues there of trying, if you want to actually combine things from different sites. So our thought was, let's look at, we generate the knowledge at the individual sites, and then we try to make sure it's standardized so that we can actually do those comparisons. But we did combinations of looking at different data sources, but I think we also ran into a lot of the issues of kind of terminology issues to actually, first at one level, how do we combine the data, but also how do we combine the knowledge? And the standards are the big piece into making those things happen. I think two is we were already running into issues, even though they're on the same system, we were running into some of the local cultural practices as well as kind of terminology issues. And I think those are things you kind of want to see with bringing other institutions is what happens when you bring in additional data. And also that's just the same vendor. Then we have other EHR vendors, so SFHERE, which again is kind of set up differently. And so things like what we have at Brown in Rhode Island, we do have our hospital systems. Both of them are on Epic, but also one of them also has SFHERE as well as a range of other systems. And so things we're looking to expand and kind of see even within a single state, multiple EHR systems, even between two healthcare systems that both have Epic. What are some of the data challenges that we're going to deal with, and how can we apply those techniques? And then going to yet a different vendor, a different EHR vendor, what does their social and family history look like compared to Epic? So again, lots of open questions and opportunities.